Today's Facebook Live event will be addressing racial disparity in healthcare and the negative effects on women of color in receiving necessary treatment for gynecological conditions. My name is Nilfer Kazi, and I am the Director of Education and Community Outreach. Today, we are joined by CIGC's co-founder and surgeon, Dr. Natalia Danilians, and Abe Walker, a board-certified women's healthcare nurse practitioner. Dr. Natalia Danilians is a board-certified, fellowship-trained, minimally invasive GYN surgeon and co-founder of the Center for Innovative GYN Care in Rockville, Maryland. Dr. Danilians completed her residency at George Washington University, where she served as chief resident and received fellowship training in advanced retroperitoneal laparoscopic surgery through the exclusive Johnson & Johnson Ethicon Endosurgery program. Welcome, Dr. D.
Thank you so much for having me.
Abayomi Walker is a board-certified nurse practitioner specializing in women's health. She holds a bachelor's and master's degree in nursing from the University of Pennsylvania School of Nursing. For over 10 years, she has been providing high-risk and routine obstetrical, postpartum, and gynecological care at several practices across the DMV area. Our discussion today, welcome to you both. Our discussion today will focus on racial disparity in healthcare, why women of color are so often at a disadvantage in healthcare, and the work we at CIGC are doing to help close this divide. The recent deaths of George Floyd and Breonna Taylor, the Black Lives Matter movement, and the COVID-19 outbreak have highlighted long-held inequities for people of color around the world. Those inequities are especially notable in healthcare. At the Center for Innovative GYN Care, we're committed to improving the lives of women through the treatment of complex GYN conditions, and we're working every day to make the most effective treatments available to African American women. Now, in the past 3 months, COVID-19, we've seen, has disproportionately affected the African American community, and several factors contributed to the increased susceptibility of African Americans to COVID. But before we even begin discussing those factors, it's important to preface the conversation by acknowledging that these factors are a consequence of the socioeconomic, political, and medical policies that were put in place by centuries of systemic racism. These policies have made health disparities all too common among members of the African American community. With that being said, we are very excited to be here today to discuss this topic. And to get us started, I'd like to turn to Abayomi. And if you could just give us an overview of the pre-existing health conditions in the African American community and kind of explain how that led to their increased susceptibility to COVID.
Yeah, thanks. So there are a lot of factors that you previously discussed. Some of the pre-existing conditions that we know increase susceptibility or even risk for COVID-19 are age. So particularly people over the age of 65. Also, people who are living in long-term care facilities or group homes. That also includes people who might be in prisons or in the carceral system, just because there's more dense population of people. Anyone with an underlying health condition, people who have had transplants, if you are diabetic or immunocompromised, people who have had bone marrow transplants, anyone who also has liver or chronic kidney disease increases their susceptibility to COVID just because their immune system is not as robust. Obesity also impacts your risk to COVID. And then there are also environmental, economic, and social factors. So where people live impacts their exposure to COVID. if you're in a more densely populated area, or a city for that matter, then you have greater exposure than someone who's in a rural area, right? Then there's a reliance on public transportation. Again, if you're in a city, it's easier to commute by train or mass transit. That increases your exposure to other people. If you are living in a house and you have multiple generations in that house, so it's maybe the nuclear family of a parent and child, and then maybe you have grandparents who are living there also. In some instances, you might have multiple generations in a household, and they are not able to effectively isolate the more susceptible members of that household from the healthier people that may be going about their everyday business. Again, that impacts their ability to protect themselves or isolate themselves effectively against COVID.
Now, can you, both Dr. Danilians and Abayomi, could you shed some light on the frequent conditions in the African American population amongst African American women as it relates to their gynecological health?
Extremely common in African American women. Sorry. So fibroids are very, very common in African American women, but there are other conditions. So it's very important to know that, you know, once you have someone who comes to you with pain or bleeding, yes, they could have fibroids, but if they don't have fibroids, or even if they do, there may be something else going on, and that's very important. And you know, we always tell other providers and patients about this to keep in mind there are other conditions. So endometriosis, for example, is very, very common in African American women. Adenomyosis, which is endometriosis of the uterus, is very common in African American women. So I think, you know, first it's important to think of the woman, right? So what are some conditions that are common, period. And then, of course, keeping in mind the fibroids are number one. So perhaps even somebody who doesn't have problems, screening those patients for these common conditions. At the well woman exam, so Abayomi, once she comes back to us, she can talk about that. But it's very important that during the well woman exam, just during the pap smear or during, you know, check for any other conditions, we have to check for fibroids. And how do we do that? Not just with pelvic exams, right? Because we know those are not accurate. This was probably being done for 100 years before ultrasounds even existed, but now we're in 2020, so we need to be more progressive in the way we treat patients. And doing a pelvic ultrasound is certainly very easy. The majority of the practitioners have pelvic ultrasounds in the office. So why not have this patient who's just coming in for a regular pelvic exam, you recognize this is an African American woman or a young female. I need to do an ultrasound because I need to make sure she doesn't have fibroids, because if she does, you know, I need to address that. I need to help her. I need to educate her and prevent all these comorbidities that she could potentially be dealing with these because of these fibroids if they get missed for many years, which happens all the time.
And I think often as patients, as female patients, we go into a doctor's office and we don't know if our OB/GYN, if our GYN specialist is not requesting an ultrasound for us. As patients, we should ask for it. And often we put in so much trust because there's a level of authority when it comes to physicians that we think that, oh, they're going to automatically do an ultrasound for us, but that may not be the case. So I think that highlights the importance of taking an active role and requesting an ultrasound. Now, Abayomi, I would like to just circle back, and could you touch a little bit on how the role of the lack of access plays in the susceptibility of just conditions?
Yes. So we know part of part of being able to treat fibroids effectively is one, to be able to get in to see a provider. And that is where access comes in. So do you have insurance? If you don't have insurance, which for a lot of people is pretty common, or you don't have access to quality providers, that's also an issue. Black people are 2 times more likely to have gone without health insurance in the last year in comparison to white Americans. So for women, we know that's a factor. If you don't have access to a provider, then you certainly can't get the diagnosis and you can't get treated. The other thing is economics. So some patients may have health insurance, or I should say would-be patients may have health insurance, but if their deductible is cost prohibitive, then they're going to put off being seen because economically you can't afford that. Add in this COVID crisis where people are furloughed, people are unemployed, and having a procedure or surgery that's considered elective, or seeing a doctor for something that you may or may not be able to afford, you end up putting that care off. That visit gets put off.
Right. Thank you for sharing that. So when we look at the research when it comes to fibroids in African American women, the evidence is very clear that fibroids are more common, aggressive, and severe among African American women. In fact, Black women are 3 times more likely to develop fibroids and have an earlier age of onset when compared to white women. And I think both Dr. Danilians and Abayomi can speak to that. When African American patients are coming into the practice with fibroids, they're a lot younger, in their early 20s and 20s, versus white women coming with fibroids, they're in their early 30s, mid 30s. And along the way, we see that disparities are present in every step along the journey of fibroids for Black women. There was a study conducted. You won't be able to see it, but we'll provide the link for this study. It was conducted in 2013 by Elizabeth Stewart and her team of researchers. There was a national survey sent out, over 800 respondents, and because there is limited research looking at race when it comes to fibroids, Stewart and her team sought to examine the racial differences in the overall experience of fibroids for women. And what they found was that when compared to white women, African American women reported a higher occurrence of symptoms. They were significantly more impacted by heavy menstrual bleeding and abdominal pain, and they were significantly more likely to experience impairment of their relationship with friends and family. What they also found was that Black women were more often reported that fibroids interfered with physical activities, and therefore they were more likely to miss days from work. Two of the main key concerns for Black women in this study was future fertility and pregnancy. And just to give a statistic to put numbers on it, 71% of African American women said that preserving their uterus was very important to them, versus 41% of white women. Now, all these findings really speak to the massive burden of fibroids that African American women are carrying throughout their journey of their condition. And every step of the way, their quality of life is heavily impacted. So when they have these symptoms all these years, they finally reach the point where they're ready to seek treatment. And the research shows that African American women have a 7-fold increased risk for having a myomectomy compared to white women. And I mentioned before that in this study, they indicated that preserving their uterus and fertility was extremely important for them. But despite that, the research shows that Black women are almost 3 times more likely to undergo a hysterectomy for fibroids than any other racial group, which is mind-boggling. And on top of that, African American women wait longer to seek treatment. They wait on an average of 4 years longer compared to white women. So this cycle, this in turn creates more concerns regarding complications and consequences of treatment options available, often compromising their fertility and leading to a hysterectomy. And so here at CIGC, our research team really wanted to figure out, why are African American women waiting 4 years longer than white women? And we conducted a focus group a few years ago, and we still have research underway to address this question. And what we actually found was that Black women do in fact wait 4 years, 4 years more than 4 years to seek treatment for their fibroids. And we initially theorized that this was due to the unintentional normalization of fibroids in the Black community, meaning mom had fibroids, mom had the same symptoms, grandma, auntie, they all had bloating, painful menstrual periods, heavy bleeding, so it must be normal. I'm just going to put this off. So that's the unintentional normalization theory. That's what we thought it was on the patient's end. However, from our own focus groups, we learned that this passivity does not rest within the patient, but rather the physician telling the patient to either have a hysterectomy or to watch and wait. And this is what leads to African American women waiting longer to seek treatment. And now I'd like to ask Dr. Danilians if you could tell us what you see at CIGC as it relates to fibroids.
Yeah,
in our
I think there's multiple factors. One is, again, going back to screening. If the physician or nurse practitioner, medical provider recognizes the fact that you have the population who's at higher risk for fibroids, we need to do screening. We screen for cervical cancer, right, with pap smears. We talk about HPV vaccines. This should be part of the conversation and part of educating women, especially Black women, that fibroids are a significant risk, just like high blood pressure or diabetes, right? We talk about those conditions all the time. And so we need to start screening. If we screen, then we can catch fibroids earlier on, and we can treat these young people instead of waiting. Because what if somebody's not symptomatic, right? So of course, we don't want to put all the responsibility on the provider, because if the patient is having pain or having problems, but for some reason they never see a provider, yes, the condition goes undiagnosed. But if there's no symptoms, the patient has no idea. Maybe they know about fibroids, maybe they don't, but they themselves don't realize there's something going on. It's the responsibility of the provider. Also, I have to say that, of course, if you don't have access to medical care, you're more likely to miss these conditions. But even patients, I've seen patients who go to the doctor every single year for their pap smears. They've been doing everything they're supposed to be doing. They're trusting the provider to diagnose them with anything, abnormal going on. And these fibroids go missed because pelvic exams are not accurate. We're not all, 90 pounds. So heavier women, you do pelvic exam, you can't feel anything. But even on small women, you just can't feel. You cannot feel small to medium-sized fibroids. When their fibroids are giant, the patient themselves knows there's something going on. So we're missing these diagnoses early on that can prevent then, infertility. But yeah, if we wait till the uterus is huge with numerous fibroids, that even when we try to do a myomectomy, because sometimes patients come to us and say, I want to preserve my uterus for fertility. I'm still young, but my doctor says there's no way, we will have to do hysterectomy. So we do try to do a myomectomy in those cases, but the uterus is so damaged from years of fibroids that even if you can preserve the uterus, a lot of times the fertility is gone, unfortunately. So it's, it's delay in care. It's like the biggest problem with fibroids, and even in patients who have access to it.
Could you talk to us a little bit about, and this is a question for you both, maybe we can start with you, Abayomi. What is and isn't normal when it comes to pain? So how do we know? Go ahead.
There are a couple of things. Duration. So how long does the pain last and when is it coming? And is there either an underlying cause that the patient can kind of point to? So for instance, if your period starts and you have cramps and your period ends and the cramps subside and you don't have pain again until the next menstrual period, that might be considered normal. More importantly, if you take something for your pain. So does your pain respond to Tylenol or ibuprofen or Aleve? Or is it unresponsive? So pain that's unresponsive to over-the-counter pain medicine is not normal. Pain that is debilitating, and this happens a lot, if you take your pain medication and you find that you are constantly taking this pain medication and it's not subsiding, or if you're having pain and it's days on end, you know that when your period comes that you are not going to be able to leave the house or you're going to have to call out of work, that's not normal. So pain that limits your functionality or diminishes your functionality, that's not normal. If you have pain that's disruptive repeatedly throughout the month, that's not normal either.
Yeah, I definitely agree. I think an important thing to remember is that don't let tell you that your pain is normal, whether it's your family member, saying, oh, my periods are bad too, like, don't worry about it, it's maybe part of our family, or the provider, which happens all the time, saying that, everything seems normal, your exam is totally normal, it's probably just your bad periods. And even if you get an ultrasound, remember, yes, ultrasound can say fibroids, but there are other conditions that ultrasounds or CAT scans or MRIs will miss. So if, like Abayomi said, all those kind of the nature of your pain, if it's really altering your quality of life, majority of the time there's something going on, and you should ask for a second opinion. You don't, a lot of times with patients who have a very good relationship with the physician, and I think that's great, but you don't have to feel bad to ask for a second opinion. I mean, certainly, even among family, right? We can disagree. We love each other, but we still can disagree, and it's okay to go to someone else and say, if all my tests come back normal, I just don't feel like my life is normal. This pain dictates when I can go on vacation, or me hanging out with my friends, or me taking care of my kids, or doing my work. So something is going on, and there are other ways to find out where the pain is coming from. So you have to be your own advocate. Just remember, even though it sort of sounds very sad, that no one else is going to advocate for you except for you.
Thank you both. Can you both just speak to, sorry, I'm losing you both. Okay, you're back. Sorry about that. And I just wanted to be clear that we treat women at our practice, but you both have also treated transgender women that came to our practice. Can you speak to that a little? And how fibroids affect transgender women?
Well, yeah, if you have a uterus, you can have fibroids or endometriosis or any of those issues. So regardless of how other people identify you or how you identify yourself, if you have those structures, they can cause problems. So the same thing, coming to the provider and advocating for yourself if you feel that there's something going on. And if it takes 3 or 4 people to go to, then you should do that. Absolutely.
Absolutely. I think it's time for us to take some questions. Let me see here. So I see a question here. Are there studies pointing to stress as a factor in fibroids? And how does diet affect the development of fibroids? Two very good questions. I don't have the answer to that right now, but I can definitely point you to some studies. At the studies on our blog post. There are studies that, sorry, the connection's kind of in and out. There are studies that point to stress as a factor in fibroids, but stress is like one of those things that, and I think you both can speak to this, it's an inflammatory response in your body. So it causes and intensifies a lot of conditions. But I can definitely look for some studies.
I can add to that a little bit. I've definitely seen patients who've, had bleeding, let's say, or pain due to fibroids, and they've said, reducing the stress or changing their diet have helped their symptoms. We have to be careful though, because, the fibroids are still there and they're still growing. So I don't think that by taking the stress away, you can, reverse the process. These are benign tumors, and they're dependent on hormones and on blood supply. And then if there's, both of those things are happening, they're going to continue to grow. Again, the symptoms can be reduced, just like they can be reduced with certain medications, right? But the fibroids are still there. So we don't want to ignore the condition itself, even if the symptoms are getting better with some of the treatments, or maybe, let's say, acupuncture for pain. But we want to remember what is actually causing the pain. Yes, we're maybe reducing it, but is there this underlying cause? What is it? Is it going to cause eventually infertility because I've been, waiting this long and just treating the symptoms rather than underlying tumors or disease or condition?
So those complementary treatments subdue the symptoms, but it doesn't get rid of the fibroid. Basically, that's right. The point.
Exactly. And I think that's a lot of times, again, providers and patients make that mistake of treating the symptom. And if the symptom, it's almost like, oh, great, I'm good to go. I don't need to do anything else. But it's sort of false hope or false sense of security, I guess, whatever you want to call it, because later on, the fibroids all of a sudden very large, or endometriosis is all of a sudden very extensive, and now nothing is helping, and how it's very difficult to reverse the damage that's been done by the endometriosis or by the fibroids.
Right. We have another question. Is a heavy cycle a symptom of fibroids?
I'm sorry, I didn't hear the question.
Can you say the question again?
Is a heavy menstrual cycle a symptom of fibroids?
Yes, heavy menstrual cycle can be a symptom.
It can be. It's not exclusive. With endometriosis, you can have heavy bleeding sometimes. With fibroids, you can have a lot of different symptoms. There are what we call bulk symptoms. The fibroids are large, so they're pressing and causing pressure. They might cause early satiety. So after you eat a few bites, you feel full. You might have urgency or urinary symptoms because the bulk of the uterus is putting pressure on the bladder. Heavy periods, bleeding in between periods, feeling fatigued also, especially if it's around the time of the menstrual cycle. That could be related to the presence of fibroids because of chronic blood loss. Sometimes patients have an increase in their abdominal weight. So your abdomen is getting bigger. You might even feel the fibroids Sometimes patients will actually feel the bulge as the fibroids are increasing in size. There are a lot of different symptoms, and sometimes even after surgery, patients will have had symptoms that they didn't even correlate with their fibroids. And once the fibroids are removed, they think, oh, wow, I didn't even realize that was because of my fibroids, but now I don't have that issue. So there can be a lot of symptoms. That's the best way to put it.
Yeah, and just because you don't maybe have severe symptoms doesn't mean that there's not a lot of bad stuff going on, because all the patients are different. Fibroids, depending on their location, are different. So it's just going to be important again to do imaging, do a second opinion, and screen early on, regardless of the severity of or presence of symptoms.
Now we have another question here. With combined oral contraceptives, will the estrogen increase the size of the fibroid, or is it such a small amount of estrogen it doesn't affect the size of the fibroid?
So the estrogen in the birth control pill is very low. So it should not affect the growth of the fibroid. It also, your ovaries, make a ton of estrogen. There's a lot of estrogen released just before ovulation or with ovulation. So no, birth control pills are not necessarily going to cause the growth of the fibroids. But remember, so if you're using the birth control pills for the fibroid symptoms, you have to be careful. Yes, you're not causing them to grow with the birth control pill, but they're just still growing, right? So you might be just sort of delaying the treatment, and again, treating the symptom, but not the condition itself.
One question here regarding women who are menopausal. So for women who are menopausal, how important is it to treat fibroids? Are there other things these women should be aware of?
That's a very good question. So I see a lot of patients who are, maybe they haven't gone completely through menopause, but they're, let's say, around 50 years old, and they have fibroids, and maybe the fibroids are causing some of the symptoms. Maybe it's bleeding, maybe it's just pelvic pressure, and they feel that, and maybe they were told, they don't just feel this, they were told, well, why don't you just wait till menopause? I mean, your bleeding will stop, right, with menopause, and then the fibroids will shrink, so you're going to be fine. You need really surgery. I mean, certainly if we're talking about small fibroids, this might be okay. Although anytime someone is having abnormal bleeding in a perimenopausal range, that's not normal, and that does need to be checked out right away because of the higher risk of uterine cancer. But even just large fibroids that are bulky, there's again this false sense of security. I will go into menopause, the fibroids will go away. They do not go away. They typically don't grow after menopause because lack of hormones. But if you have a giant fibroid this size, it's not going to be like this after menopause. Even if you wait 20 years, okay, it's still going to be big. So I always tell women, your fibroids are not going to get much smaller. So if you're okay with living with this pressure, pelvic pressure, the rest of your life, I mean, that's what it's going to be. So I still recommend doing surgery in some cases of large fibroids, but it can affect sexual activity, right, because of pain. If you have this giant mass in your pelvis, certainly can't be very comfortable. There's also hormonal changes already going on, plus you're adding fibroids to the discomfort, and then of course it can affect sexual function or a lack of desire and things like that. So fibroids just they're there. They can cause problems whether you're 20 years old or you're 60 years old, and I think again we just have to make people aware that they're not normal. Something that's common is not necessarily normal. Diabetes and high blood those regularly. So
Yeah, I like that. Just because it's common, it's not normal. We just have to always remember that. I have a question. Before I ask you a question, Naomi, I have a question for our audience. Do you feel like your pain has been normalized in your community? And if so, how? You can feel free to answer it in the chat. I'll just repeat that. If you feel like your pain has been normalized, how so? And Abayomi, can you talk more about racial inequities in maternal mortality rate and your thoughts on how to address this?
So there's an increased maternal mortality. There's increased infant mortality within the Black community in the United States, and it's deplorable. I think if we had, of course, access, right? So access to high quality obstetrical care, access to quality postnatal care, and also access to quality GYN care during your fertility period, right? So women have to have a relationship with their providers so that they trust the guidance that they're receiving from their providers, that they feel like they are able to ask questions and receive an informed explanation for any concerns that they have. We also need to make sure that lifestyle changes that we know will impact future fertility, the ability to carry a pregnancy healthily, that those things are a part of everyday wellness visits. So we do Well Women visits here, and a part of those visits is discussing exercise, discussing your nutrition, right? So the things that will contribute to providing you with a healthy foundation at the time that you plan to try to get pregnant are already a part of your lifestyle. I think those things are important. It's not so much saying during pregnancy is the time to get healthy. While that's beneficial, you want to come into the pregnancy as healthy as possible. So what can we do as providers to facilitate you getting healthy before you get pregnant? If you have, it's pertinent to this discussion, if you have fibroids, those can impact your fertility. So what are we doing to address those fibroids? Timing pregnancy so that we maximize your ability to conceive naturally if you have that possibility, and not delaying care, but really making sure that it's a collaborative experience.
Thank you, everyone. We have another question. I believe this one's for you, Dr. D. When does the provider decide to do a laparoscopy when diagnosing endometriosis?
if it's endometriosis is suspected, that would be kind of the simplest way of answering that question. If endometriosis is suspected, you do laparoscopy because you can diagnose it, you can remove it. So that's what you have to do. I think putting somebody, okay, so if let's say someone who's 16 comes to me and they say, my periods are painful, but they've never tried birth control pills, they don't, again, pain of course is very subjective, but let's say they're still able to go to school, and the pain goes away after 1 or 2 days, of the period, but they haven't really tried, taking ibuprofen or birth control pills. Am I taking them right away to the operating room? Probably not. So I will, tell them to use birth control pills, give it a 3-month trial, ibuprofen, like that. But if I have somebody who's going to the ER every time they have a period with vomiting, and excruciating pain, I think I'm probably not consult them by offering birth control pills at that point, and use my judgment and my experience that usually in such severe symptoms, majority of the time it is endometriosis, and it actually can be pretty severe even in somebody that young. So I would take them, I would offer laparoscopy to them, make sure if it is endometriosis, we remove it, and then after that, that's when you go in with birth control pills or some type of hormonal suppression, rather than just telling them that all the list of things that they tell you they're experiencing and how they're suffering. You just say, well, here's birth control pills, come back in 6 months, and we'll talk about it again. So
laparoscopy is the only definitive way to diagnose it, right? You can't do it through ultrasound or imaging.
Right. Yeah. Exactly. So ultrasound, fibroids, ovarian cysts, that's ultrasound. But endometriosis, typically patients will have normal ultrasounds. Sometimes we do MRI if we suspect endometriosis of the uterine muscle, but you still need to do laparoscopy to see if there's endometriosis outside of the uterus. So yeah, and I mean it's outpatient surgery, right? Small incision, so it's not so invasive to the point where we need to delay it as a last resort. It really should be the first step, endometriosis, because endometriosis, it's a chronic condition. You don't just cure somebody with endometriosis, but just as with fibroids, early diagnosis is really so important in basically helping someone's quality of life, essentially helping them preserve fertility. I mean, you could really change someone's life by just doing eating.
Right. Absolutely. I'd like to read some of the responses to the question I just posed. So we asked, do you feel that your pain has been normalized in your community? And the response from Tanya has said, I'm noticing if you're not extremely assertive, some providers do not listen. I've had to ask a couple to listen. It's a very good point. And we have another response here from Arthuretta. If you mean our symptoms normalized, do you mean our symptoms marginalized? The answer is yes. You must know more about your health to even have discussions with doctors. Absolutely. Sunny says, yes, that's part of the racial biases we encounter. Have to continue to speak up, switch providers, and encourage others to do the same. Absolutely. Thank you all for sharing. We have reached the end of our session. And in closing, I'd like to say that all of us at CIGC want to empower you to take control of your health and get the treatment that you need. That includes.
Sorry, I have one more comment. I don't want to, because there was a comment. Especially when the GYN is a man. I mean, you have to pick who you're comfortable with, okay? Because again, if the provider is not on the same page with you and they're not hearing you, just go to somebody else. This is not a marriage, right? Even if you've been seeing them for 20 years, 30 years, it's fine. They have other patients, they'll totally be okay. You just move on, you find somebody else that you like and that you connect with, and who's giving you the right treatment. Because you may like their personality, and you may feel like they're very super nice and they seem compassionate, but you're just not getting anywhere with them. Please also move on. I don't think you're gonna really hurt their feelings, because you just have to care about you. Okay, that's all that's important in life, is you, your family, but don't worry about your provider, even though if you have a 20-year relationship with them. Fine.
Yeah, you're not cheating on them.
Yeah. No. Yeah. I just
yes.
To okay. Add,
they'll forgive
on
you.
top of that, we need to. Patients are talking about being advocates for themselves. And I think that's important. Yes, you should advocate for yourself. You should educate yourself. If something doesn't seem right or if something doesn't feel right, you're allowed to acknowledge that symptom and that feeling and go seek another provider. But I think it's also important, as we're winding down this discussion, there is a reason for patients to be hesitant, to be reluctant to seek care. And I think this kind of goes back to the research that you were talking about, why Black women might be delaying care, because there is a history of experimentation, of procedures being done without patients being fully consented and understanding the consequences. So that has to be acknowledged. And when you're searching for a provider, you do want to make sure, as Dr. Donnellian said, and as Neely has pointed out, you want a provider that's on the same page, that you two have similar goals to your provider. So if you feel like you're being put off, if you feel like your symptoms are not being taken seriously, then see another provider.
Thank you, everyone. I'm being told we have one more question coming before we close up. But it's not coming through. So I'll just say.
Sorry, I don't want. Makiba had a question about birth control. I think is taking birth control pills for a long time make you fertile? Well, that's a little bit of a trick question. It doesn't make you infertile. let's say it that way. But if there's some underlying conditions that maybe birth control pills are, because they're relieving the symptoms, maybe you're not aware. Let's say you have endometriosis. It could be mild, but the birth control pills are controlling those symptoms. So you may not even realize there's endometriosis until you come off the pills, and that all of a sudden kind of it surfaces. But birth control pills themselves wouldn't make you, infertile. And they certainly can decrease the risk of uterine cancer and ovarian cancer. So they're not bad for you. You just have to be careful that, again, you're not covering up some underlying conditions that will in fact cause infertility.
Okay, that was the question, Dr. D, that I was looking for. So thanks for catching that.
Okay.
Okay, now we're going to start closing.
Yes.
So we talked about how pelvic exams are not a sufficient way to find and diagnose something like fibroids. And so don't let anyone dismiss your symptoms. Ask for an ultrasound. You know your body best, and you're your own best advocate. It's important to remember that gynecological conditions like fibroids are a surgical issue and cannot be managed medically, as both Dr. Williams and Abayomi expressed. So many women of color are told by their physicians to watch and wait, and that their pain is normal. And just like Dr. D said earlier, it's common, but it's not normal. And in terms of racial disparity, we know that there's not enough research being done to find out why people of color are not able to access the same level of care as their white counterparts. One of the shortcomings in fibroid-related research is that race is omitted, a critical issue given the disproportionate impact of the disease on African American women. We see those gaps in the research, and we here at CIGC are actively working to fill them. So if you'd like to look more into the research that we discussed today, we'll have a blog post up next week with links to all the studies we talked about and I referenced today. And for those of you with pain and other gynecological symptoms, please know that you're not alone. If you'd like to tell us more about your health journey, please visit www.innovativegyn.com/racial disparity to take our women's health survey. Thank you all again for joining us today to talk about these important issues in women's health. Thank you, Dr. D. Thank you, Abayomi.